Good morning, and welcome to a discussion of advanced contrast echocardiography. This is going to be essentially everything except left ventricular opacification. And joining me by Zoom, as you can see, is Jonathan Linder. Now, Jonathan would like nothing better than to be here live and in person, especially since he picked the wines for the past president's dinner last night. But after ducking it for 30 months, the COVID monster finally caught up with him last week, ironically 2 days after his second booster. But anyway, I'm delighted to see that he is on the mend, and he will join us for Q&A. Say hello, Jonathan. You're on live.
So hello, Jonathan. You're on live.
All right. Well, this is, I think, a very exciting pair of lectures that we will have today, and delighted to have our virtual audience joining us as well. Before we get started, just a couple of housekeeping items. We'd like to thank GE Healthcare for generously sponsoring this symposium. Docs and nurses are able to get 1 hour of CME credit for this, and sonographers can get 1 SDMS CME credit. You just have to fill out the appropriate form and make sure that you've had your QR code scanned when you came in. So with no further ado, Jonathan has pre-recorded his lecture, and we'll go ahead and get that started. Let's see if it's really just 1 space bar. Okay. Is it, can you make it play from there, or?
Lecture from just down the road, a little bit south in Portland, Oregon. I won't be in Portland, Oregon for long. I'll actually be relocating in about a month to the University of Virginia. So the program that we put together, Jim and I have put together for you, is meant to be aspirational. What I mean by that is we assume that everybody is now using ultrasound enhancing agents or contrast echo as part of their routine for left ventricular opacification. It is considered state of the art. It is considered what you need to be running a modern echo lab. So we're going to essentially be talking a little bit more about cutting edge applications, which is what I meant by aspirational. And I'll start off by talking about perfusion imaging, both at rest and during stress in chronic and acute coronary syndromes. Here are my disclosures with my grants listed at the top and other disclosures below that. I don't think that I'll mention if there are any conflicts of interest. I don't believe there are any in this presentation. So let's start off by perfusion imaging at rest. A lot of why we use perfusion imaging at rest is either for viability or the patient with acute chest pain. Okay, and in acute chest pain, our main job as cardiologists is to exclude or diagnose myocardial ischemia. And of course, perfusion imaging, but even wall motion abnormalities actually play a role in making that diagnosis. Now, this is really critical to exclude ischemia as a cause because there are all these other causes of chest pain, acute chest pain that I have listed here that are essentially findable by echo. And I'm not even listing all of the causes because there are extracardiac causes. And so it's imperative not only to diagnose myocardial ischemia, but also to exclude it with a high degree of confidence. Now, because of that, we'll talk about perfusion imaging, but just first, let's talk about wall motion abnormality first. So this is a schematic that I put together for Catherine Otto's book on what I think is a good algorithm for when to use contrast for left ventricular opacification, for looking at wall motion, okay? And it differs a little bit with our guidelines, which say, oh, just 2 segments. And the reason is this, which is I usually teach people to go through 2 questions. What is the quality of the non-contrast echo, poor, fair, good? And green means you're more likely to benefit from contrast. But then what is the clinical indication? Contrast is not going to help you much with your echo for pericardial disease. but it's going to help you a lot with these things up at the top, including what we're talking about now, which is resting chest pain, okay, or stress echo, which we'll talk about as well. And here's just an example of what I mean. Here's a patient in the emergency room, okay? This patient actually has chest pain. It's a decent echo. I don't see much in the way of a wall motion abnormality, okay? When I play the contrast images, you can actually see this area of complete akinesis of the distal septum. Here is another patient who has a decent resting echo, chest pain in the emergency room. We don't see all segments all that well, but it doesn't look that abnormal. When we give contrast, we can actually see this little focal area of the mid-septum. This is a patient who had a stent a couple of days ago who came back with chest pain. This person actually has stent jail. In other words, they lost a first septal perforator, resulting in this tiny little area in the mid-septum, kind of pathognomonic for that. So remember, when you're doing perfusion imaging, you get free wall motion anyway. And it's very important that you actually put perfusion together with wall motion, okay? Now, perfusion imaging. How is perfusion imaging done? Well, we generally have to establish a relatively stable concentration of bubbles in the blood pool. And then what we do is what you're seeing here. We pop all the bubbles with this flash. This bright thing that you see here is a high power transmission of ultrasound that destroys all the bubbles in the tissue. You can see the tissue going completely black, and then we see the bubbles coming back in. I don't have time today to tell you all about the technical features of what's on your system to allow you to do perfusion imaging. That's a completely separate lecture. You need to learn how to do that first. But once you do, the algorithm is this: destroy the bubbles and look at the rate and the extent of bubble replenishment into the microcirculation, okay? Now, once you know that, how do you apply this in somebody with chest pain? But also, why do you apply it? Well, the reason is somebody who comes in with chest pain, if it's active ischemia going on, you should have a wall motion abnormality. If you have normal perfusion but a wall motion abnormality, you probably got stunning. But even if you have a wall motion abnormality, you have no idea what is going on with hypoperfusion. So in other words, you can have pretty bad wall motion abnormality and have here's wall thickening on the y-axis here, and this is blood flow. You can have horrible blood flow, or you can have blood flow that really isn't all that bad, that actually will maintain viability. In other words, if you look to the right here, this dashed line is essentially perfusion, normal perfusion, and going to the left is hypoperfusion. This dashed line on the y-axis is wall motion going down, becoming more hypo or akinetic, okay? And what this graph, this is from a study showing you that as you produce mild, moderate, severe, really severe resting wall motion abnormality, so this is complete akinesis here, this is severe hypokinesis, you can essentially have severe hypokinesis or akinesis with hypoperfusion only of the endocardium. The whole epicardium and mid-myocardium may be completely normal. So you can have various degrees of perfusion despite having the same degree of essentially akinesis or wall motion abnormality. Here's an example of that. Here's a patient with a severe wall motion abnormality in the LAD distribution. And when we do perfusion imaging of this patient, what you can see is this subendocardial defect in perfusion. This is what a perfusion defect looks like. We destroy the bubbles in the myocardium, and you can see this dark stripe right through here of the endocardium. That's an endocardial perfusion defect. It didn't come in quite as fast as everything else. So that's hypoperfusion. And this is an example of somebody who has a wall motion abnormality, but has complete viability of the myocardium and has hypoperfusion only of the endocardium. So what does this mean? Well, what this means is that generally, when we use contrast, so this is a study that was done in patients, about 2,000 patients who came into the emergency room. This is the predictive value of the modified TIMI score, the initial clinical evaluation of patients, and this is the predictive value. When you add wall motion to your clinical data, you get the answer, okay? If somebody is actively having hypoperfusion, having an NSTEMI or a STEMI, you get the answer immediately with wall motion. Perfusion imaging does not add that much to just making the diagnosis of an acute coronary syndrome. So why would perfusion imaging at rest actually help you? Well, because what it does do is it helps you determine what the physiology is. So here are 3 different patients in the emergency room. all of them with an LAD wall motion abnormality. This is an acute emergency. This person came into the ED, has this hypoperfused apex through here. It is akinetic, so we made the diagnosis. But look, no perfusion whatsoever. This is an emergency. Get to the cath lab now. Here is a patient who actually has a wall motion abnormality just here at the apex, but eventually it fills in. It's hypoperfused, but eventually the perfusion gets there at the apex, okay? So eventually it fills in. A little bit less of an emergency. It probably is urgent to get this person in the cath lab, but they're probably not going to infarct much of this tissue at all. Now take this patient who came in who got thrombolysis in the field. There is a dyskinetic septum, and yet perfusion is not only normal, it's hyperemic. It comes whooshing back in. This is a person who has stunning. There is no need to rush this person to the chest to the cath lab. Stand down. This person has had complete reperfusion. Okay, so that's where perfusion at the bedside kind of helps. And this is some from that big study that was done in the emergency room. This is the outcomes. This is the event-free survival, showing that a lot of the events happened earlier in terms of just diagnosing an acute coronary syndrome. Of patients who presented to the emergency room with chest pain who got perfusion and wall motion with contrast. Normal function, normal perfusion, decent prognosis. Abnormal function, abnormal perfusion, bad prognosis. But these people who had abnormal function but normal perfusion, people who came in with some stunning, actually had intermediate. So you can really determine that somebody is going to have a better course by determining they have had reperfusion, either spontaneous or because of something that you have done. Now, the other thing that contrast helps you in this situation is even if you know you've got myocardial ischemia, it helps you, as I've just shown you, it helps you determine that you have achieved microvascular reperfusion. And this started decades ago with Hiroshi Ito, who studied microvascular no reflow with contrast echo. It is considered one of the gold standards for diagnosing this. So once you've had PCI, you can have essentially closure of the microcirculation from all kinds of things, from microemboli or in situ thrombosis or spasm or edema from cell injury, all of these things that tend to close off your microcirculation. And Hiroshi showed using intracoronary injections of contrast that you could essentially diagnose whether or not the microcirculation was open or not, and showed that it was very important in terms of recovery of resting function and long-term prognosis. It makes sense. You're going to recover function if you've reperfused the microcirculation, and you're not going to recover function if you haven't. And so these days we can actually do this with more modern techniques. So this is a patient who underwent acute PCI at our institution, and you can see that there's a wall motion abnormality, and there's been reperfusion here of the septum, and there's kind of reperfusion of the epicardium here, but the apex is not reperfused and will not recover. Okay, so that's microvascular no reflow after reperfusion. Now, those are some of the uses in patients with chest pain that are directly due to ischemia. But remember, perfusion imaging can help you even when the diagnosis is not from ischemic heart disease, because chest pain can be from other things. And here's just two examples. Here's one, which is a patient who comes into the emergency room with chest pain, wall motion abnormality, and salvos of VT. And here you can see that there is, hopefully you saw this, videos are having a problem playing. There's a wall motion abnormality of the lateral wall and mid-septum, okay? Subtle hypokinesis here and here. Perfusion imaging, though, just focus on the septum. Perfusion in the septum was completely normal, okay? We kind of lost the lateral wall here from a rib artifact. Completely normal perfusion. Here is somebody who has a wall motion, and this is actually the same person. Here's that wall motion abnormality right there of the mid-septum, and here's perfusion. So these are atypical wall motion abnormalities for coronary artery disease, plus they have completely normal perfusion. So we got steered immediately that this was from something else that can cause wall motion abnormalities that are focal in a non-coronary distribution with normal perfusion. This is a little later in this hospitalization. We said this is absolutely not ischemic heart disease. This person was actually diagnosed with, of course, sarcoidosis on their PET CT. Another syndrome that we have started studying is acute COVID. So acute COVID infection, especially in those who are hospitalized, can cause positive troponins. In those who have positive troponins, you're more likely to have complications like pericardial effusion and ventricular dysfunction. And the ventricular dysfunction is from a lot of things. It can be from viral myocarditis or the inflammatory myopathy from cytokines, Takotsubo or sympathetic stress response with a stress cardiomyopathy. But it can also be from SARS-CoV-2 infection of the vasculature causing either a direct infection or a cytokine vasculopathy or a thrombotic angiopathy, the procoagulant activities of the viruses that cause the microcirculation to essentially clot off. And we don't know which these are without having the tools to be able to study that. And that's exactly what we've done. This was a study that was done by Tom Porter and I, a 2-center study of patients with COVID in the hospital with positive troponins getting echoes. And what we found is a pretty high percentage of patients who had abnormal EKGs and positive troponins who had these really funny little patchy perfusion defects that I'm showing you by these arrows here. And that was all from thrombotic angiopathy. So the bottom line is if you use perfusion imaging, you have the tools to be able to find all of these different syndromes that can cause either non-ischemic or even non-coronary artery disease, ischemic wall motion abnormalities in areas of myocardial injury. Let's finish up with talking a little bit about stress echo and stress perfusion. Here's the problem. Here's a patient at peak dobutamine. On your left, this is actually perfusion imaging, but you can see on the wall motion here, I don't see much of a wall motion abnormality during peak dobutamine on this person. My perfusion imaging, though, shows me the presence of a perfusion defect right there at the LV apex, okay? So the perfusion of the septum is normal, but it's delayed right through here at the apex. Here's the apical 3-chamber view showing you the same thing, normal wall motion, but delayed reperfusion right through there of the LAD distribution. So this is a person who we diagnosed with coronary artery disease based on perfusion, but not wall motion. And yes, this was real. That is what their LAD actually looks like. They actually had bad circ disease as well. But the bottom line is this person had severe tight LAD disease that we were able to diagnose only with perfusion imaging. Now, why is that? Well, it's because of this relationship. This is the relationship between blood flow during peak exercise or peak dobutamine and wall thickening. And what this shows you that is if you have kind of a moderate stenosis, you cannot differentiate people who are completely normal with normal perfusion from people who have mild to moderate stenosis sometimes. And so directly looking at perfusion will give you enhanced sensitivity. It is just a reality. This, my friends, is why stress echo does not have 100% sensitivity. It's not because we don't know how to read studies. It's because of this relationship, which is nonlinear between wall thickening and blood flow during peak exercise or peak dobutamine. All right. So if we do perfusion imaging, we should be able to improve sensitivity. Here's another patient. Here's a patient with multivessel coronary artery disease. And here is their stress echo. Okay. Their stress echo shows this is wall motion. So hopefully what you see there is at peak stress, you see a wall motion abnormality in the LAD distribution, and that's it. Okay. So you can see that this apex does not look normal. But we were not able to make able to make the diagnosis of this being multivessel coronary artery disease because the circumflex distribution looked just fine in terms of wall motion, right? Now, when we look at perfusion, we see something completely different. We see that perfusion defect involving the LAD distribution, but if we tilt over here to the lateral wall, we see the subendocardial defect right there of the lateral wall as well, okay? So what I did here is I just captured the first frame after destruction and then replenishment, showing you blood flow in the septum, blood flow in the basolateral wall, the epicardium here, but there's an endocardial defect here and a transmural defect here. We were able to make the diagnosis of not just coronary artery disease, but of high-risk multivessel coronary artery disease, which we did not necessarily see on wall motion abnormality at peak stress, okay? And because of this, studies like this one from Abdu Al-Hindi has shown that you can actually improve your sensitivity for detecting single vessel disease, especially as you see over here, if the degree of stenosis is less severe, using perfusion imaging in blue compared to just wall motion, which is red. But especially it helps you diagnose multivessel coronary artery disease, okay? If you have multivessel coronary artery disease, wall motion will help you make the diagnosis of coronary artery disease, okay? It fares a little bit better than with single vessel disease. But what contrast does is it allows you to identify multivessel disease, but it also allows you to detect multivessel or single vessel coronary artery disease if it's not as severe. Finally, I'm going to finish up with one last thing, which is microvascular abnormalities, all kinds of diseases that can cause, and I told you about some of them like COVID or microvascular no reflow, but increasingly we're interested in functional diseases that affect the microcirculation. Essentially primary microvascular dysfunction. These are diseases where there's abnormal balance between constrictors and dilators that act mostly in small arterioles or large arterioles to essentially cause spasm when there's supposed to be dilation and causing microvascular ischemia. Okay, this is what it looks like when you act. This is this is microvascular dysfunction when you look at it under a microscope. This was a model that we developed in our laboratory, and these are like, you can see these individual red cells through here just trying to get through these areas of spasm of this arteriole, and it's all caused. It's not one disease. It's caused by any imbalance between all of these vasodilators and all of these vasoconstrictors. Now, the reason why it's really important to be able to make this diagnosis is it can produce symptoms that are more than mild. Patients are not happy when you just they're being told, oh, you're okay, you may have symptoms, but your arteries are free of obstruction, nothing to do, and sent out. Prognosis is not benign. Prognosis is every bit as bad with microvascular dysfunction as it is with CAD. And there are current therapies that actually work for it. And there are new therapies that are being developed and need some way to be able to follow these patients and their perfusion abnormalities at the microcirculatory level. And then there's this last point here, which is there's some recent data that suggests that mortality from non-cardiac disease, including cancer, is really increased with those with microvascular dysfunction. So you got to diagnose it. So how do you diagnose this? Well, we have ways of diagnosing it now with perfusion imaging. This is regadenoson contrast echo. 4-chamber view in a middle-aged female, chest pain, CTA, showed no coronary artery disease, completely normal blood flow in the apical 4-chamber view at rest, hypoperfusion right here during regadenoson stress. It'll loop again. You're going to see right there in the subendocardium of the apical lateral wall a perfusion defect. We diagnosed this woman with primary microvascular dysfunction, put her on therapies. Her chest pain essentially completely resolved. But we're also using it for other things like transplant vasculopathy, where this is resting perfusion in this person, which we destroy the bubbles and it takes forever for them to come in at rest and even during stress. And this is the quantitative curves just showing you that there's really no flow reserve during regadenoson in this person. So this is a person who we're able to diagnose with transplant vasculopathy. So our laboratory is actually routinely now doing vasodilator stress contrast echo for the diagnosis and assessment of microvascular disease, because we really don't want to have to send these people for 3-hour studies in the cath lab for all the vasodilator testing needed for that. So I will sum up here with this, which is, these are my conclusions, which is, here are some situations where if you are interested in learning perfusion imaging, these are the reasons why you should, is for bedside or emergency room diagnosis of ischemia. It helps with that. Stress imaging, especially, so stress perfusion imaging, especially in those who have a resting left bundle branch block, or in those who have pre-existing wall motion abnormalities. You guys know that detection of wall motion, of like biphasic responses, is really difficult in people who already have some hypokinesis. Evaluation of microvascular dysfunction or transplant vasculopathy. We're actually using it in patients who are donor hearts for transplant. If somebody has stress cardiomyopathy, wall motion abnormalities, very common in these hearts, we're able to essentially confirm that with bedside perfusion imaging. And then there's other things that I didn't really talk about, like tumor perfusion imaging, but also this, I hinted at this with the COVID case, which is thrombotic angiopathies, which are really an area of that needs to be explored more. So thank you for your time and attention. I'll now turn the program over to Jim.
All right, thank you so much, Jonathan. The top of your head, there you are. You're on the screen there. That was fabulous, and I think people are all eager to go out and take a look at how they can do contrast perfusion in their laboratories. Let me kick over to my slides. If you want to keep listening, I may need some assistance from you along the way. So, and then we'll certainly have time for questions at the end. Let's see if this is going to go. Okay, and how do I hate this presenter view. Can I just get rid of that? Or maybe I can, if I just look down there, I will try not to be distracted. All right.
Let me get this right. You can restate the Euler equation, but you can't get your slides up?
The slides are up. It's just in that annoying presenter view that I hate. But anyway, now I'm going to show them a picture of you, Jonathan, to say many thanks to Jonathan for providing these slides. The only thing closer would be if I was the ventriloquist dummy and you were here mouthing them for me. But I'm also making the case to the audience that there will be a very intense contrast symposium and workshop at Echo Hawaii next January 16th to 20th, 2023 on the Big Island. You can see Jonathan and me there. We will be directing and co-directing. So please join us. We've done a contrast perfusion workshop for the last couple of times, and it really, really will teach you how to do this in your own practice. So please join us. And now let me launch into some therapeutic applications of contrast ultrasound. First, we need to remind ourselves of the bioeffects of ultrasound. First of all, there is just simple thermal effects where you can use ultrasound basically as a deep tissue warming agent there. If you turn the intensity of the ultrasound up, though, you can actually get tissue cavitation. That's where the negative pressure of the ultrasound waves essentially forms a vacuum, and you can, in essence, boil off some of the gas dissolved in blood. That can be significantly enhanced if there are ultrasound enhancing agents or contrast agents, which will give much more forceful cavitation. You know that it is possible to focus ultrasound to get a shock wave, like shock wave lithotripsy. And then there's also this notion of sort of ultrasound pressure causing convective motion and shear with applications like reattaching detached retinas and things like that, where you very gently push on structures and get them back into place. And so the use of cavitation for therapy has multiple applications. We'll talk briefly about thrombolysis. We'll talk about nonspecific increases in perfusion. We'll talk about gene and protein delivery, and then tumor and tissue ablation we won't deal too much with, but that is certainly a possibility with high-intensity focused ultrasound. Now, this is work from Lisa Villanueva's lab, just to illustrate what this looks like, where you are using cavitation to dissolve away thrombus. And just to orient you a little bit, these are microscopic images of a microbubble sitting on top of a layer of thrombus. And notice that the speed of the imaging is about 5 million frames per second. So this is ultra high speed film imaging there. That was one microbubble being ablated on the left. Now we'll look at 3 microbubbles, and you'll see how they pulse and get larger and larger and ultimately rupture. And at that point, you can really see a big divot left in the thrombus there. See them bouncing and bouncing and kaboom. And what you're left with at the end is a divot in the layer of thrombus. And just imagine repeating this millions and millions of times, and you would gradually erode away that thrombus. Now, that's the principle behind taking patients having STEMIs and taking them on their way to the cath lab, providing ultrasound agents and doing cavitation with insonification. And this is some work from my friend Wilson Macias down in Sao Paulo, Brazil, where they randomized 100 STEMI patients, 50 to just standard of care, and 50 receiving high myocardial intensity contrast-enhanced ultrasound. And as you can see, the results comparing the cavitation versus just standard of care, ST segment resolution occurred in 32 versus 4%. TIMI 2 to 3 flow was seen in 48 versus 20%, both highly significant. And even looking out 6 months to see if there was a need for an ICD, 5% versus 18%, and that too was statistically significant. So I think this is a very promising treatment. As long as you're not delaying the definitive care, it seems like it is only a winning combination to try to thrombolyse before you even get to the cath lab there. Now, there are direct vascular effects of cavitation in both chronic and acute coronary disease, and just showing that in the epicardial coronary arteries, we can get mechanical fragmentation of plaques. We can get the penetration of lytic proteases into the, yes, better if it was bourbon, but I'll take it. And change the actual mechanical properties of the vessel to better conduct the blood down it. Now, in the microcirculation, which, as Jonathan showed, is really where a lot of the action is, you can also fragment distal emboli, you can fragment microvascular thrombosis, you can decrease microvascular tone, that is, make it more conducive to blood flow, and there are shear-mediated endothelial antiplatelet and anti-inflammatory effects that take place in the vasculature like this. Now, this is some work on the left here is relatively old work showing a rabbit femoral artery occlusion and then using 40 kilohertz CW Doppler at fairly high intensity there, and those are the crosshatched bars, the darker ones, and you can see that those both here looking at it over time and down below where there were different degrees of insonification, you clearly see improved perfusion in the tissue, and this is thought to be related to nitric oxide synthesis, and that's been shown in this study here from Dr. Siegel's laboratory, again about 20 years ago, and showing the dotted line here where you give a nitric oxide synthase inhibitor, L-name, and you see virtually no recovery of flow in these cases here, and but with the provision of ultrasound cavitation, you get near normalization of tissue perfusion downstream, and this is in a coronary artery model of a dog myocardial infarction. Now, looking at augmenting tissue blood flow with microbubble cavitation, here we see Todd Belsick, who's worked with Jonathan for many, many years, and demonstrating the very significant recovery of function with cavitating ultrasound particles there, and near normalization, dramatic increase in the perfusion that you can see here, both in an analog fashion and then quantitated in this graph. This is work, again, from Jonathan's laboratory here, looking at Jonathan, one of his second jobs is being a monkey doctor there. He has a whole group of baboons and macaques and such at the Portland Primate Center there, and he's learned a great deal from looking at these animals who he's given many of them names. They're chronic animals, so they're around long enough to get to know them, And you can see here that in the four-chamber view, which was the insonified view, there is a very dramatic improvement in perfusion, as you can see post-cavitation here. This is now looking in human peripheral artery disease. And I think this is a very exciting potential application of ultrasound to take patients who have chronic, severe peripheral ischemic disease, and simply by applying ultrasound cavitation over a period of sessions, you can improve the chronic perfusion of that vessel and reduce the need for revascularization or even worse, amputation in these. And then a very, and I should mention that study was done by one of our imaging fellows at Northwestern who is just graduating, O'Neill Mason. And then finally some recent work again by Todd Belsick out of Jonathan's laboratory looking at patients with sickle cell disease and how applying several applications of contrast cavitation, you can improve peripheral perfusion in these patients that have chronic ischemic disease from their sickle cell disease. Now, I'm going to have to ask Jonathan what a pannexin channel is, because I never learned that in my medical school, but this is taking primates that have peripheral artery disease and then applying ultrasound both in a single plane and then as a three-dimensional insonification, and again showing that the more extensive the cavitation is performed, such as with the three-dimensional imaging, the higher the myocardial or the muscle blood flow is in these animals here. Again, a very promising approach to working on peripheral vascular disease. Now let's turn our attention to a little bit of gene therapy and ask the question, how can you get genes into cells? And I think there are several ways that sonoporation, or the use of contrast ultrasound, can help deliver genetic particles into cells. First of all, just kind of nudging a little pore open like this with just low mechanical index pulsating of the bubble there. You can also have sort of a suction effect that will pull the material into the cell. When you are chronically pulsing there may be a little jet of flow that goes through there, microstreaming, and then this acoustic radiation that just gradually nudges against the tissue until it yields and the genetic material can be delivered. And there are a whole host of targets that could be taken for gene therapy. You could look at hepatic or liver disease for the dyslipidemias and Wilson's disease. You can do renal vascular hypertension, primary hypertension, and then a whole host of cardiac and peripheral arterial effects with a lot of genetic potential therapeutic agents such as VEGF and SDF and a number of these other ones. So let's just look at a few experimental models that these have been used in. Again, most of this work is Jonathan's, so I'll ask him to explain this a bit more when we have him back live. So here we are looking at site-targeted delivery and therapy for, this is a mouse hind limb ischemia model here. And you can see that giving these contrast agents in increasing doses, you get more and more peripheral perfusion with this. But very important that the microbubble be cationic in nature, that is, have a positive charge. If it's a neutral bubble, it doesn't seem to penetrate very well. Here is ultrasound-mediated gene delivery of VEGF to develop proangiogenesis in the ischemic hind limb. And you can see much more than GFP. VEGF generates this rich plexus of capillaries that greatly improve perfusion in the ischemic hind limb here. You can see at 3 days it is dramatically higher than it is in the control arm. here's something called Survivin, which I just love the name of it. It sounds like something that will yield immortality, but this is looking at cancer, chemo-related cardiomyopathies, and showing that delivering this genetic component Survivin into cells will preserve cardiac function. You can see here, this is a in-systolic elastance of an animal given doxorubicin with a severe flattening of the in-systolic pressure-volume relationship, but pre-treating with Survivin leads to this much steeper pressure-volume relationship and preservation of the myocardial function. And here's something that I never thought I would see in a echocardiography meeting, is ultrasound-mediated gene delivery for reversing placental insufficiency. Yes, that's correct. I said placental insufficiency, which apparently is a problem in baboons. And by delivering the VEGF into the placenta, you can prevent the occurrence of placental insufficiency enough to allow the full pregnancy to go on. So again, when Jonathan said he was working with pregnant baboons, I was a little surprised. So in summary, ultrasound produces pressure and shear-related bioeffects that can increase cell uptake and trigger calcium-dependent processes. These effects of ultrasound are markedly enhanced by microbubble cavitation. The shear effects can increase tissue perfusion at the site of ultrasound and downstream by conducted effects. Ultrasound cavitation can augment gene and drug delivery through stimulated cellular uptake and microporation, and there are several therapeutic advances being developed for clinical use. And as I said before, please join us in Echo Hawaii next January to learn more about all of this, and also just have a very nice time out in the sun when the snow is about waist deep back in the Midwest. So thank you very much for your attention. Let's take the slides down and bring Jonathan back. And I hope that you have been putting some of your questions into the application. I'll read them off and see if we can get some of Jonathan's thoughts on this. So thank you very much. Jonathan, can you hear us?
Yes, barely, but I gotcha.
I just need to have this microphone turned on down here. Okay, now we've got it. And let's see, do we have any questions in our, so first of all, Jonathan, what's a pannexin channel? And can you explain that a little bit more? I felt a bit out of my depth there.
I actually will not describe what a pannexin channel is, but I'll actually operate at a much higher level. So whether you guys know it or not, or meaning to do it or not, if you are receiving signal from a bubble, whether you're doing left ventricular opacification or perfusion imaging or anything, if you're receiving the signal from a bubble, you're vibrating it. And when you're vibrating it, you're not just producing an ultrasound signal for you to do your diagnostics, but it's producing fluid shear, okay? I don't have to explain that too much. It just makes sense that when something kind of rings, it produces some shear that moves out. And shear is a really, really important stimulus in health and disease. And so shear can augment blood flow, it can be anti-inflammatory, it can be anti-clotty. And so the bottom line is when our laboratory and others have studied, what are we doing? How are we producing all of these interesting effects on flow and inflammation and thrombosis? Some of them are related to shear, and shear has to be transmitted to have its effect through certain channels. Pannexin channels is just one of them that essentially triggers the release of a lot of good stuff that's involved in anti-inflammatory and in flow augmentation. So the bottom line is that the main point for people to remember is, we vibrate bubbles to get their signal, and that can actually be used for good.
All right, that is great. I am not sure that our question and answer program is working. Let me try this again. Okay, no, now I've got it. All right. Eric Tran asked a few seconds ago, are there any side effects of interventional echocardiography, such as damage to the myocardium? Sounds too good to be true. Well, I will give a short answer. I think for the most part, the imaging mechanical index that we're using in there and the way it's distributed across the field means that you're not going to get any real impact on the tissue. Jonathan, any concerns about essentially diagnostic echocardiography in causing issues with the myocardium?
Yeah, Jim, you pretty much just nailed it by saying diagnostic. So if you go looking through the literature, you can see that we can produce petechia and microhemorrhage and some problems if we actually vibrate these bubbles too violently. And as it turns out, that threshold is just beyond the FDA limit for diagnostic ultrasound systems in terms of pressures. And so it's very interesting that we have been very fortuitous that we're operating in the with diagnostic scanners at the right frequency, just below the harmful pressure, threshold for producing some of these bioeffects. The other thing, Eric, to answer your question is, we don't fully understand all of the mechanisms behind augmented delivery. Not all of it is probably from poration. Some of it is probably from stimulated uptake of genes and drugs. So when you vibrate these bubbles, produce shear, you essentially stimulate the cells to start sampling their environment, for lack of a better term.
All right. Brian Brindle asks a very cogent question, who says, for those of us who are not able to make it to the Echo Hawaii workshop, are there other resources to get set up to begin resting and stress perfusion imaging, which I think someone as smart as Brian needs to figure out a way to get to Hawaii. But Jonathan, we do actually need other ways of educating people, and where would you point them?
Well, number one, I think what we'll have to do in response to that question is start up a GoFundMe site for Brian to attend Echo Hawaii. In actuality, it really is one of the few ASC or ESC, any society programs where we do live imaging, not just LVO, but also for perfusion and for how to, it's both sonographers, people like Todd and Jim Hodovan and myself and other experts in contrast. We show you how to prepare the agents, all of the different agents, how to infuse them or bolus them, and then show you how to image them on the different systems. Now, there is, if you want to get started with the policies, your lab policies, the ASE actually has what we refer to as the handbook for contrast policies that talk about things like safety and consent and all of that, and reimbursement and all that business. But that's not how-to kind of stuff. So if you are not able to make it, for example, to Echo Hawaii, and you really need to see it, my recommendation is go visit, even for a day, a laboratory that is actually doing live perfusion imaging on patients, because I'll be honest with you, it's one of those things that's really hard to learn just from reading a paper or from watching a presentation.
And I think what you've identified is a real gap in our educational material, and maybe we need to work to develop something that really goes, step by step, how to prepare the agent, how to do the imaging, and things like that. Because, like you say, just reading the papers, you don't get a lot of the real nuance as to how to really do this in your own laboratory. So, excellent question, Brian. And if you do get a GoFundMe site going, I'm sure Jonathan will contribute to it. So, thanks so much. Here's a nice question. Jesse Navarro asked, what is the mechanism behind back pain for Dfinity? And I know, Jonathan, this is I've heard him talk about this, so I know he has a lot of insight into this. So, Jonathan, take it away.
Yeah, our laboratory has done a lot of basic research on this, and here's what I can tell you: we don't know. In actual, we kind of do know. There's 3 or 4 main hypotheses. The one that's kind of risen furthest to the top is the fact that the bubbles can actually produce a little bit of stuff in your bloodstream downstream from complement activation. So the bubbles get removed from the circulation, in about 5 minutes. You guys know that. You give a bolus, it's gone in 5 minutes. Why? How does it go away? Well, it's complement mediated. Your body has a way of saying, ooh, bubbles, foreign membrane, let's get rid of this. And then you get rid of it, and it involves some complement. Well, downstream from that complement process is the production of bradykinin and some other stuff that can stimulate nerve receptors. So in actuality, when you have that flank pain, it's probably not doing any harm. It's just the stimulation of nerve receptors, primarily that are primarily located in the kidney, where bubbles tend to do a little bit of sticking as well. I won't go into why. There is a paper that we published on this if you want to look at it. And I'll end there. But very, very good question. The bottom line is it's not doing any injury to the patient. Just stop the contrast, and generally it goes away with a little bit of time.
And Jonathan, do you have any data or observations on if a patient has had this reaction one time? Are they likely to get it if they're exposed to the same agent in the future?
Yeah, we actually don't have any data on that. We do have a couple of patients that we know have had it. We also have a couple of patients who actually, got one lipid agent but not the other in both orders, and didn't have it the second time. So the biggest thing that it's dependent upon is dose. Mm-hmm. So people who give whopping huge doses are more likely to see this. The other thing is, in certain diseases that are complement activation syndromes like sickle cell, you may see it a little bit more.
All right, we're getting more questions in. Eric Tran, now officially a frequent flyer on the Q&A, says, first, thanks for answering the first question. You're quite welcome, Eric. And it says official echocardiograms, by which I mean sort of full-featured Doppler echoes, take some time to perform and increase the time to PCI. Do you feel it is feasible to do contrast perfusion imaging with POCUS handheld devices as a screening tool? And also, I guess I would extend that to say the sort of insonification that they were doing in the STEMI trial down in Brazil. Is that something that could be done with a handheld POCUS ultrasound to get the effects of cavitation and sonothrombolysis?
Will you answer that, Jim?
I think, again, it all depends on the types of mechanical index that can be generated by the POCUS machine. And my guess is that it is designed for diagnostic imaging, so you probably can't get it up high enough, but that doesn't mean that some clever engineer couldn't produce an instrument that would deliver high enough mechanical indices to rupture the microbubbles and do the thrombolysis. Is that your sense? Does like a V-scan or a butterfly give high enough mechanical index to rupture bubbles?
Yeah, we kind of don't know the answer to that, because there really hasn't been a lot of work looking at dose response in terms of the ultra. If you're looking at flow augmentation, it is essentially ultrasound dose or power related. For the sonothrombolysis, we don't quite know that yet, but I think you're exactly right, which is it's probably just not ideal for doing that. Not only that, but a lot of the work that was done with Tom and Wilson, they essentially used perfusion imaging to kind of guide where they were hitting the bubbles. And the point of care, the small handheld point of care ultrasound systems are not really set for being able to give you perfusion imaging data, that's for sure.
Yeah, but I think it's something that, looking to the future, if this is proven to be, valuable to do with a full-featured echo machine, then someone will figure out how to engineer it into a handheld package. There's no physical reason why this should be impossible. It just needs some engineering work on it there. One other question here, David Kardesh asked, is there any value of intracoronary contrast agents during PCI as a therapeutic for no reflow?
Well,
these are some great questions. There's some people really thinking about this. So what's my sense is you would increase the contrast intensity there, and you probably would maybe ameliorate the no reflow situation. But is there any data on that, or any thoughts, Jonathan?
Yeah, so no, there's not a lot of data on that. Here's the deal on that, which is if you go looking deeply into, for example, the first clinical trial on this that you mentioned, Wilson Matthias's trial, they got every bit as much benefit out of RCA stenosis as they did, or occlusion, as they did for LAD. And if you think about the way that they were imaging, they never hit the right coronary artery. They hit the distal microcirculation. So in other words, the most important thing is to kind of get stuff to the distal microcirculation. And one of the things that we think could be happening is the augmentation of collateral flow as well. And if you inject it directly intracoronarily, you're not going to essentially get any kind of effect on collateral flow. The other thing that I believe very strongly about, and has not been mentioned, but folks in my laboratory are studying this very, very carefully, is that maybe a lot of the beneficial effect from the sonothrombolysis trials was actually from bubbles vibrating in the left ventricular cavity, where they essentially hit red cells and release a bunch of good stuff that we're studying downstream. And you can get that from an intracoronary either. So the bottom line is, it sounds like a great idea. I think somebody probably needs to study it. And I think somewhere in the past, Tom Porter may have studied intracoronary versus non-intracoronary in his pig models, but I'd have to look that up.
All right, that is great. And I think we have come to the end of our questions, and we've also come to the end of our time. But I would really like to thank the audience for providing some stimulating questions for us. I would like to extend a rapid and complete recovery to Jonathan, including his keen sense of smell and appreciation of good wines. But you do look to be significantly on the mend, Jonathan, and thank you so much. Any last words?
No, thanks for everybody for attending. Here's the bottom line of this symposium of advance, which is in the future, the thing that is going to keep echo as a subspecialty and as something special as we get more and more users of basic echo is essentially some of these advanced technologies where we are not only able to do bedside perfusion, which is very unique, but eventually echocardiographers will become therapeuticians, if you will, people who are actually delivering therapy through their knowledge of ultrasound.
All right. Let that be a challenge to you all, and thanks for your attention. Bye-bye.